So the topic is not exactly what you have. What I was emphasizing was the changing face of complicated pneumonia in the era of pneumococcal conjugated vaccine. It's still in Philadelphia, wishful thinking. And this is about pneumonia. Pneumonia, or my preference is to call it lower respiratory infection, or LRI, is a highly prevalent entity in childhood, as you probably know. It's the largest single cause of morbidity and mortality worldwide in children, less than 5 years outside of the neonatal period. Statistics from the Western world suggest an annual incidence of 3 to 4% of the pediatric population below age 5, a substantially higher number than that of adults. It is important to acknowledge that the review today may not be reflective of very large, low-income parts of the world. So we are really focusing on the realities of our existence. And I'm not going to talk much about pneumonia. I'm going to try to talk about complicated pneumonias. And what these will include is pleural effusion or empyema, lung abscess, bronchopleural fistula, and necrotizing pneumonia. And as you will see, the bronchopleural fistula is really in large part a discussion on necrotizing pneumonia. So what I would like to point out is that the recent literature suggests that hospitalized children in the United States with pneumonia or low respiratory infection, to be precise, predominantly have infections with viruses. And these are the ones, RSV, rhinovirus, etc. And only when you go to Mycoplasma pneumonia, if you consider that a bacterium starts to show up here. But the real pneumonias are much, much less prevalent. So you need to remember that what I'm talking about here predominantly relates to the bacterial pneumonias and very little to the viral pneumonias. One other thing to remember, and this is a wonderful study that everybody should know about, is that when we're talking about viral infections, or for that matter, other infections as well, much of the time these are mixed infections. So in this column, for instance, this dark part is RSV, and this lighter part is RSV plus. So that could be a mixed infection of other viruses, virus and bacteria, etc. So our simplistic approach that we're dealing with pneumonia that is by single etiologies is not always correct. I'd like to start to talk about pleural effusions and empyema. And I am not going to give you the answers that you are seeking. I will just give you some directions about how to think about these things. So empyema literally means purulent appearing, or it looks like pus. And there is a variety of definitions how to do that based on components of the fluid that you're removing. But really the reason that we want to deal with that is that this is a predictor of complicated outcome. And that's really the reason that we're transitioning from calling it a pleural effusion to calling about empyema, which is the one that we dread and that we don't want to see. And so the most common way to make the diagnosis of that, since we know that X-rays are not particularly sensitive, and certainly CT scans are not as sensitive as they should be, is by doing ultrasounds. And here you see an anechoic fluid suggesting that there is pure pleural effusion. While if you look at this one here, it's an echoic effusion, it's septation, and it suggests that you have a complicated pleural effusion, meaning that you are starting to see the loculations that I will see you in real life. But this is really the only way to pick up the loculations very clearly and very rapidly. Now, how do you approach the pleural fluid? And this comes from the adult literature of old days. Richard Light has been for years the guru of pleural effusion, and this suggests that the sun should never set on a parapneumonic effusion. So if this is the adult approach, I think it was to some degree the pediatric approach, and really is not that anymore. and we're much more permissive about what we tap and what we not. And when you make a decision about yes or not to tap, or what yes or not to drain, here are the things that you need to think about. The things that you need to think about is that you start with a fluid that is an exudative phase, which is free-flowing and is low cellularity, and is really not very damaging. But if this is a pleural effusion that is an empyema or actually will complicate, then you will be eventually organizing the fluid. It's an organizing phase that is largely fibroblastic activity with peel formation, and basically the consistency of this is gel. And once you get there, you really cannot do very much with the needle, and you'll either have to take the child to surgery if you need to get rid of it, or wait for it to go away. In the interim between these two phases is the fibropurulent phase, where you see fibrin accumulation, abundant polymorphonuclear, and loculation, which is what I show you with the ultrasound. And the transition from this to this is about 2 to 3 days. So the window of decision-making is pretty narrow. You need to make up your mind whether you're dealing with a complicated effusion, you're dealing with an empyema, and do you need to do something about it? So this window is relatively narrow. And why is that important? Because if you miss that window and the things are complicated, and at that point in time, you cannot just put in a needle and drain, this is what you get. And this is VATS, or video-assisted thoracoscopy, and this is a lung that needs to be collapsed in order to be able to work within the pleural space that really is a virtual cavity. You need to form your cavity. And when you collapse the lung, you see these strands of fibrin that are causing these compartments. These are the loculations. So imagine that you need to put a needle from the outside into one of these loculus, then you won't be able to drain any more than that. And at this point in time, you really need to go to surgery. And this is an example of a surgery where the surgeon needs to actually remove all these strands of fibrin until you get a pink background. This is the chest wall, this is the lung, and this is the end of the procedure. But this is pretty invasive and of course needs to be done under general anesthesia and by a surgery. Here is just another example of how you look from one loculated area into the other. So there's a window here because it's torn, because the lung has been collapsed. But as a matter of fact, in reality, this is a complete wall and they are separated from each other. So how do you know that this is going to be a complicated effusion? How are you going to know that this is a pleural effusion that is going to be becoming an empyema? Well, I don't know whether you need to know, but if you want to know, what are the predictors of a complicated outcome? If you tap the fluid, then the markers that you should be looking at are pH, glucose, LDH, and cell count. A low pH is the best predictor of a complicated outcome. We know that the pH of the normal fluid is essentially alkaline, and if you go to acidity, then you know that this is probably a bacterial infection and is going to get complicated. The same for glucose. If the glucose goes down, that probably means that you are dealing with a bacterial infection. And if you're interested, there is a paper by Mitri, M-I-T-R-I, that actually combines the two as predictors and also goes into the great detail why these are the best predictors. And while they are not commonly used, you should remember that if you need to know, these would be the 4 parameters. And the thing to remember is cell counts are not particularly helpful. So what do you do about it once you decide that you have a pleural effusion and you want to do something about it? So there is a number of approaches here, and they are different and they are still argued about to this very day for many, many years. The current most common approach is that you just leave things alone. You give IV antibiotic therapy and delay the pleural tap and delay the pleural drainage. And there are 2 studies, one by Epo in 2006 that was a controlled study, and Carter that was not a controlled study, but get to the same opinion that you don't really need to do anything about it until the child really declares himself and is febrile, is not resolving with the antibiotic treatment, and then you need to go. The missing piece in that is that there is no long-term follow-up on the kids where there was a delay and the decision to make something about it was delayed. Are they going to have a more complicated outcome? So this is one approach. Another approach that has been quite widely tackled in the literature is a thrombolysis and a pigtail drain. Now, a pigtail drain is a small drain, a non-surgical drain, can be done in the ICU or in the invasive radiology. And then for 3 days, you inject thrombolytics, and that dissolves the septations and allows you to drain. And this has been, again, tackled quite widely in the literature. Another approach is to actually decide that you are going to do a video-assisted thoracoscopy early on and not wait for complications, and that has been very popular in the early 2000s and remains in some parts of the world. And one that is much less popular is repeated ultrasound-guided needle thoracentesis that was published from Jerusalem in 2002. I don't know that many people are using this. So really the question is that when you decide to do something, are you going to do a video-assisted thoracoscopy or thrombolysis with pigtail? And there is one, the earlier study that compared the two was by Sam Sonappa from London in 2006. And she compared two groups, one that used the pigtail drain with urokinase versus the VATS. And the conclusions were the results are essentially the same. So whether you take the child to VATS or you do thrombolytics via pigtail, you get to the same results as far as the length of stay and complications in the hospital. In addition to this study, there have been at least 3 or 4 others that did this head-to-head comparison. And the conclusion is that they are more or less equivalent in the outcome. So this is a study that a paper that I should not really be citing. This is under curfew, it's in press. It's a paper that Fernando de Benedictis with a number of us from 5 continents have put together. This is going to be published in the Lancet within the next few weeks. And that the paper is complicated pneumonias. And there is this paradigm about how you make the decisions about yes or not to drain. And I will not elaborate on that, only to refer you to this upcoming paper but there are other more complicated paradigms that have been approached before that I'm not going to belabor on. So if we look historically at what triggers this discussion is that in the early 2000s, we started to see that there is actually a marked increase in the incidence of pleural effusions in the United States. And these were the years when the conjugated pneumonia vaccine, the PC7, was introduced. And it was sort of non-clear why we're seeing this rise. And this is one thing that I would like to be tackling here. And before I go there, I would like to approach my favorite topic, which is necrotizing pneumonia. Necrotizing pneumonia is a cavitating pneumonia that is usually due to streptococcal pneumonia. And this has been known, this is a paper from 1980. Necrotizing pneumonia or massive pulmonary gangrene has been a dreaded complication of pneumonias in the adult and typically led to resection of the part of the lung that is affected and essentially was unknown in pediatrics until 1994, when this paper by Eta Kerem from Jerusalem and Yaakov Bar-Ziv, who is a great radiologist, was published about 4 cases of necrotizing pneumonia ages 1 to 7.5 in the context of bacteremic pneumococcal pneumonia in children. And basically what they were showing, and this was a first CT study on this condition, showed that CT will pick up what they called liquefaction of the lung. that the prolonged course of this is typical, up to 20 to 26 days. And unlike in adults, this actually has a pretty good prognosis even without a surgical approach. And so what happened with pneumonias around those years in 2010, the time where pneumococcal vaccines were introduced between, so they started around 2000 and became prevalent to 2006. When you look at community-acquired pneumonias, there was a marked reduction from 1997, when this approach started of immunizing children, to 2006, particularly in the very young children, not so much, and in fact an increase in the older children. So community-acquired pneumonias in the very young have improved substantially in response to this vaccination. However, the community-acquired associated complications actually were different. So when you look at any complications, and now we're talking about two types of complications. One is local, that includes empyema, lung abscess, necrotizing pneumonia, or bronchopleural fistula, versus systemic, which is complications that would use to respiratory failure, acute respiratory failure, ECMO, and conditions that will take you to the ICU. So when you look at all the complications that emerged between 1997 and 2006, actually what happened is that while the community-acquired pneumonia went down, the complications went up by 28%. Now, interestingly, this trend was starting to show in 2000, which is early on in the course of PCV. So this could have been interpreted at the time as unrelated to the PCV, was just a secular trend. Things like this happen in the history of infectious diseases, but eventually it has been associated with PCV7, as I will show you in a minute. So that's for any complications. Local complications actually went up by 77%, so dramatic, and goes hand in hand with what I showed you about empyemas, that they started to go up. And in fact, the local complicated pneumonias were driven by predominantly empyema that has become substantially more prevalent than before. However, the systemic complications went down by 8%. So overall, the most impressive thing about here is that the local complications have dramatically increased, and the overall complications increased as well. If you try to show what happens by age, any complications went down by age, mostly by age 1, and all the other ages, actually any complications went up. If you look at systemic complications, decline have been shown in the first year of life, but not affecting any other ages. And local complications showed a dramatic increase at all ages related to PCV7. And again, the local complications predominantly comprise of empyema, but I'll talk a little about the necrotizing pneumonia. This just summarizes what I told you before. So let's talk a little about pediatric necrotizing pneumonia. So, and what I'm showing you here is really historical. I'm showing it because it is dramatic. I'm showing it for you to understand the concept of necrotizing pneumonia. And this is just an example of a child in the mid-90s, a 3-year, almost 4-year-old, who has been very, very febrile for a number of days. And she refused to get out of bed for 2 days. And at that point in time, the parents, who were scientists in Boston, decided they would take her to medical attention, because up until that point, they thought this was a viral infection. And she didn't get any antibiotics. So she came to the ER with no antibiotics and no diagnosis of pneumonia with this X-ray. And this X-ray clearly shows that there's a whiteout on one side. This whiteout probably shows a pleural effusion, because a total whiteout of 3 lobar pneumonia is essentially, non-existent. However, a pleural tap was not undertaken because the ultrasound suggested the fluid is very little, which was a wrong interpretation, but basically the child had an ultrasound and then started with augmentin, and that was the treatment based on the assumption that we're talking about strep pneumonia or Staph aureus, and that was the coverage. So this was day 4. Child continued to be febrile and very, very sick. As you can see, at this point in time, a chest drain has already been put in because it was clear that there's a collection of fluid. But what you see here, and it was not obvious at the time because we didn't know what necrotizing pneumonia is that this is graying. So this gray, under normal circumstances, would be interpreted as the pneumonia is getting better because the consolidated area are now aerated. However, we got a CT scan, and this is sort of classic and for you to take home. And what we did the CT scan because we didn't have a good understanding of why a child who has been on antibiotic, had a chest drain, was continuing to be so incredibly sick. So what you have here is a CT scan with contrast, and it's important to remember that the contrast is necessary under these circumstances because otherwise the pleura may not be painted as you want it to be, and the demarcation line between the fluid inside the lung and the fluid outside the lung may be blurred. So the point to make here is the following. You have a fluid here that is dark gray. You have a pneumonia here or a collapsed lung that is very white. But in between them, within the lung, you have tissue that is not as white as this one and closer to the fluid outside of here, which is what the Kerem paper called liquefaction. So what is happening here, and you can see it also with this window, is that this area of the lung is essentially necrotizing. Basically, it becomes a different phase. Instead of solid, it becomes fluid. And just to point out here that while the ultrasound probably would have shown loculation, the CT scan is not very good at picking this up. So this is the pleura seen because of the contrast. This is the necrotizing pneumonia. This is the outside of the lung. And this is what probably the pneumonia is where there's a consolidation. You can see that this actually affects to some degree the contralateral lung as well. This is 2 days later. And again, a CT scan was obtained because the child continues to be very, very sick. In between this drain was placed in by a surgical procedure. And so the amount of the fluid that you see here has been reduced very substantially. The purpose of this is to show you what happened in 48 hours. And to the best of my knowledge, the paper that we wrote about this is actually the only one that picks up the rapid transition from liquefaction to cavitation. Remember that this same disease across the ocean in England is called cavitatory pneumonia. It's the same process, except they are looking at the cavitation and we are looking at the necrotization. Remember that 2 days before, this area was gray and fluid, and at this point in time, it actually has become cavitation. I know it is cavitation, and I'm not sure that you can see it on your computers, but you see that the structure inside of this is not the same thin structure with alveolization that you see here, but it actually is large cavities that communicate. And basically, if this perforates, this will collapse. And in fact, that is what happened later. One other point that I would like to make here is that you see that the wall here is very, very thin. So this is not an abscess. The typical abscess wall is a thick wall with fluid collection and the aeration of the abscess occurring much later. So this process that happened in 48 hours is really not an abscedation of the lung, but rather a cavitation forming after necrotizing pneumonia. On day 9, we didn't do a CT scan anymore, but what you can see here is exactly what I said, is that the cavities that you can now see in the lung actually have probably perforated. And now you see a pneumothorax here. Okay, the lung has now collected air. This is not a tension pneumothorax. It probably is because of leakage and probably the collapse of the lung and the leakage from the lung to the pleural space brings about this air collection that you can actually see here very clearly. This is air. This is lung and possibly inside and outside of the lung, because the demarcation line here between the pleura and the pleural effusion and the inside of the lung that is necrotizing is not at all clear, not on this window and not at this window. Probably there is a communication between this, probably a bronchopleural fistula, but you can see here, again, this is 3 days later, this is day 9. You would never get CT scans with this frequency in necrotizing pneumonia nowadays, but this was done because we did not really understand what we're dealing with. And so we have the historic record of the early days. This is day 25. Child has started to be less febrile around day 15 to 20, responding to antibiotics. But you see what happened to the lung. Essentially, the lung has largely vanished. This lung is now recovering. This is either inside or outside of the lung. It's unclear. This is gray. This is either fluid in the pleural space or necrotizing pneumonia. But you see that there's large amount of air now here, and this is probably just loculations that are outside of the lung, but the inside and outside are not clear. The point, however, is that this lung has essentially been destroyed. This is May 9. 4 months later, this is an X-ray that shows very little damage. So not much damage has been remaining without any resection, without any surgical intervention. And in fact, in September, which is 9 months later, a CT scan was obtained to try to understand what this very sick child, who is now doing okay, has as a residual. And what you can see here is that the recovery of the lung is essentially complete, with the exception of some changes here, which may be either scars or some abnormal bronchi. And how these bronchi have recovered fully is a mystery to me to this very days, but this seems to be a full recovery. And when PFTs are done on these children, they are actually recovering quite fast. So just to give you the extent of the repair that we see on this lung, January to September, dramatic improvement, suggesting that we don't really need to do any surgical resections. I have to introduce a caveat here, however, to say that this is true much of the time, but necrotizing pneumonia can be a killer, very rarely so, but you can never relax until you see this child actually responding to antibiotics and getting better, because very rarely a resection is necessary. And in my career here in Miami, we've seen a child with bilateral necrotizing pneumonia who we could not save. So we published this paper on necrotizing pneumonia in 2008 in the European Respiratory Journal. It remains the largest study on necrotizing pneumonia that is published to date. This was from Boston Children's Hospital, and I'm circling this necrotizing here is because it's spelled with an S, and that's why if you do a literature search with a Z, you will not find this paper, despite the fact that, as I say, it's the largest public study on necrotizing pneumonia. So the way we approached that, we looked at all the X-rays, the CT scans that were done between 1990 and 2005, looking for necrotizing, we did not find any between 1990 and 1993, which is clear because we didn't even know that necrotizing pneumonias existed before the Eitan Karen paper in 1994. And then once we have identified all the cases that were about 120 within these 15 years, Bob Cleveland, who was the radiology author on this paper, reviewed all of them and identified 80 cases that were bona fide necrotizing pneumonias, and they were the ones that we analyzed for the purpose of this publication. So the mean age in our population was 3.6 years, started with a very young child who was 3 months old, and I'll show you that one, and ending up with adolescents that were 19 years old, were very rare. And the main conclusions from this study, which look at 80 patients, is that 96% of patients reported initial symptoms of high fever, 84% had a cough, 91% were seen by a doctor prior to admission, and essentially when they came, where they were largely on antibiotics, an important point to make here, 53% required oxygen supplementation. The mean duration of fever was 6 days, and the mean length of stay was 15 days. This is markedly different from regular pneumonias. Regular pneumonias within 48 to 70 hours of the appropriate antibiotics should defervesce, and they typically do not need to stay in the hospital more than 3-4 days. So this is very different. And mean duration of antibiotics, because of many cases of complications, were 13 days, and some of them lasted up to almost 100 days. So this is a very uneven profile of a disease that can be very dramatic. So here is the year course of what we have seen in this Boston profile. In 1990 to 93, we saw nothing. In the 2 years, 93 to 94, we identified 1 case. And after that, every cluster of 2 years showed at least 11 cases. And by the time that the study was completed and I left Boston, we had 28 necrotizing pneumonia cases. Now, remember that Children's Hospital is just one of 3 children's hospitals in the city. And so that might mean that we, in Miami, we saw in Boston, we saw at least 50 to 75 cases during this year, 2003 to 2004. And across the ocean, that's Newcastle on Tyne, they were reporting an increase in empyemas and were showing also increase in cavitatory disease, which is what we call necrotizing pneumonia. In this year, 2002, they had 14 cases of empyema in that center and 4 cases of necrotizing pneumonia. So this started to show not only in Boston, but in other parts of the world. And so after that, after our publication, it became sort of a concept that has been well recognized by pulmonologists and even by generalists, and certainly children who were admitted to the hospital were started to be recognized as having necrotizing pneumonia. We're talking after the year maybe 2008 to 2010. Mistakes in diagnosis have occurred and still happen. But there was much less in the literature about that. And as a matter of fact, when I looked at the literature, the last publication that I could find was in 2013. And this was from Paris, looking at necrotizing pneumonia in 1 large medical center. So out of about 1,000 community-acquired pneumonias showing in the ER, and about 200 of them being admitted, what they were able to show is up to 14 cases of necrotizing pneumonia in 2009 to 2010. And this was the year of H1N1 in Paris, so that may have played a role. But over these years, they have seen 6 to 10 to 12 cases per year in this single hospital. So they were still there. So, but I thought that the numbers are going to be going down, and in fact, it probably is not so important anymore until this paper was published in 2017 from a very reputable center in Queensland, Australia, 2017. Just this is 9 years after the publication of our paper. And the paper is a review paper about necrotizing pneumonia and asks the question whether this is an emerging problem in children. And this is 8 years after we published our paper. So it appears that it still is a significant problem. And the study that was published, this study in 2017, estimates the complication rate of necrotizing pneumonia as 7% in pediatric admitted community-acquired pneumonia. I think that this is an exaggerated number, but this is their take from the literature. So if we try to understand what this is about, what is the mechanism behind that, it's not entirely clear, but the few autopsy materials that have presented showed that there is microthrombi in the vessels of the lungs, and what they bring about is extensive inflammation and necrosis. So this is the liquefied material, this is the necrotic material, and as a matter of fact, the involvement of microthrombi may affect also other organs, and you see this kidney with fragmented red cells within the kidney. Although we have not seen any kidney failure, some hemolytic uremic syndrome has been reported in this case in a number of case series. So this is a complication that definitely can occur. The fact that it is a vasculitic process and that we may point out to vasculopathy is helpful, because in ultrasound you can actually potentially pick up, beyond the pleural effusion, you can potentially pick up vascular abnormalities and thrombosis in the ultrasound when you see a decrease in flow that would suggest that there's a necrotizing process. I have not personally used this, but others did. CT scan, in the paper that we just published now, that is coming to publication very soon, we stated that CT scan is not necessary to make the diagnosis or to treat. Can you all hear me? Hello, can you hear me?
Yes, yes, we can hear you.
We can.
Okay. So the CT scan is not necessary for the diagnosis, but I would recommend that if you are in doubt, and particularly if you have a combination of empyema and necrosis, then you use a CT scan, and I'll show you some CT scans of why this is. But just to give you an idea, this is a CT scan of one of the cases that we have seen in the last 3 years, and what you can see is necrotizing pneumonia, pleural effusion, necrotizing pneumonia, healthy lung. And if you ask your friendly radiologist to help me with that, they can actually define for you how much is necrotizing pneumonia, how much is healthy lung, and how much is effusion. And they can actually give you a color coding of that, so it can give you an opinion on the extent of the severity of the inflammation. Here is the same kid, where you can see that there is really very little activity on the left lung that is largely necrotic. So what our conclusion in the paper was that we think that necrotizing pneumonia is a more common condition than appreciated. CT scan is required to establish the diagnosis with confidence. Similar to previous report, our study revealed that the clinical course is typically prolonged and often complicated. So this was the 80 case presentation. And again, I would like to refer you back to this 2017 review paper that suggests that still 7% of the children that are hospitalized for community-acquired pneumonia may have necrotizing pneumonia. So I can't really tell you for sure how prevalent this disease is today. I would like to refer a little to the discussion about what are the underlying organisms. And so in the Kerem paper, pneumococcal infection was the only cause in the 4 cases that they published. Here is an analysis of the cases that we saw in Boston. And so the red are the years where we had no organism growing, never negative cultures with every technique. But we remember we didn't have PCR during those times. So these were cultures and other methodologies that we have. And essentially 52% or 42 out of the 80 cases did not have an explanation of what we had. Now, the ones that were identified, 18 of them or 23% were pneumococcal pneumonias. And the rest after that were every other thing that you can imagine. So staphylococcal non-aureus, other streptococci, fusobacterium, pseudomonas. But importantly, what we started to see in the later years, 2003 to 2004, we started to see 2 cases of MRSA. And so this is important because MRSA may be a particularly bad player here. And here is the example of the child that I told you about. This was a 4-month-old who had cavitation with MRSA. So this is a cavitatory pneumonia. This is the X-ray on presentation. Kid was incredibly sick. This was November. 4 days later, we got a CT scan that started to show a large amount of effusion and cavitation. We actually had identification of MRSA in this child. You start to see cavitation here. You start to see cavitation and large areas of necrosis with the pleural effusion. And on the 22nd, so this is already 2 weeks into the disease of IV treatment, and you see that the cavities are growing. And here is the CT scan that basically shows an almost complete destruction of the lung. So this right lung is extremely damaged by this virulent MRSA. And the good news is that when he recovered after a very, very complicated course, this is the lung 2 months later, and essentially you would not know that very much action has been happening in this lung. We didn't get a CT scan, but again, to give you an idea, what is the potential of recovery of even the very damaged lung. I don't want to elaborate too much on this, just to mention that Staph aureus the MRSA can be very virulent because of a variety of toxins that they can have. And most prevalent of these is the Pantone, Valentine, leukocidin, a PVL, which is a toxin that can destroy the lung completely and can cause necrosis. And there is one study from France between adults and pediatrics that shows a huge mortality in pneumonias with necrotizing pneumonia that are driven with MRSA with PVL. So this is something to think about. It's not very common, but as a matter of fact, some reports of necrotizing pneumonia in cystic fibrosis driven by MRSA with PVL have been published from the United States by Caroline Cannon. So as far as microbiology goes, again, just a reminder, 50% of the time we did not know what it is. So I'm going to give you just a few sentences from this in-press paper that suggests that at this point in time, molecular diagnosis would be the way to go, and PCR should be obtained on whatever material is available to you. Most importantly, the pleural effusion, even if it's negative on culture, it will still give you some information on PCR, and it most often will be negative on culture. Once you started antibiotics, the pleural effusion within 48 hours is typically not growing anything, even if the necrotizing pneumonia continues. So PCRs in this area is something to remember and utilize for every available material. Just one other reminder is that this paper from Taiwan in 2004 was a stark reminder for us that we didn't do a very good job, because these are 5 cases of children between 3 and 14 years of age with classical necrotizing pneumonia, and parenthetically, one of the few cases that recognized necrotizing pneumonia very early on parallel to us, not so much in the rest of the world, was Taiwan. And they picked up these necrotizing pneumonia cases. Turned out that Mycoplasma pneumonia was the driver and not any other of the suspected organisms. In retrospect, this could have been a large part of the non-diagnosed cases in our cases, because we never thought that we need to test for Mycoplasma. And this brings up another question, is whether when you have necrotizing pneumonia, should you be covering for Mycoplasma? And I don't know the answer, just to show that these were not unique. And a paper 4 years later from mainland China showed again a collection of a number of cases of necrotizing pneumonia that were driven by Mycoplasma. A thing to remember. I would like to go to a short discussion about what I already have mentioned, and that is lung abscess. And lung abscess radiologically looks very different from necrotizing pneumonia. Typically, the lung abscess will present like this, will be a round shadow that typically at the time that you can define that this is an abscess, there will be also already gas collection, and this gas collection will be separated with a straight line from the necrotizing fluid that is in here. So yes, this is necrotic fluid that is within a cavity, but it is separated from the lung by typically a very thick wall. This is a much more stable structure than the walls that I have shown you in necrotizing pneumonia that typically will be much more hazy than this typically one or more large cavities. This is not long lasting. Once you have this process, the cavitations will typically collapse, although as I will show you later, some of them actually will have pneumatoceles for a longer time, but they're pretty easy to separate from the lung abscess. Another reminder here is that some people, not me, recommend that you try to perforate this abscess, try to drain it, and or try to identify the organisms to get a better approach with the antibiotics. If you would do that with a necrotizing pneumonia, it's almost guaranteed that you're going to cause a bronchopleural fistula, which I'll mention in a minute. So here is the difference between a CT scan of a classical lung abscess and a classical necrotizing pneumonia. You see the demarcation line between the fluid and the air. By the way, this can be either because there's already some communication with the bronchus that allow gas diffusion from the outside, or it can be a product of the gas formation by the bacteria that are sitting here. I'm not sure that we know which is the answer to that. But you can see that there is no solid wall to the necrotizing pneumonia. And as a matter of fact, as I showed you in this specific case, this collapsed on itself within a day or two. So treatment with a prolonged course of intravenous followed by oral antibiotic. The initial choice is guided by local macrobiological knowledge, followed by subsequent positive culture and molecular testing. Importantly, should be tried on pleural effusion when available. And duration of therapy is conventionally prolonged, but no data are available for comparisons. Typically, the recommendation is certainly to continue with the IV as long as the fever lasts, and then to give a period of time, probably about 2 weeks of oral antibiotics, but there is nothing to show us that this is the right approach. Let me go back to the PCV7, because this actually is an important discussion here. So PCV7 was introduced in the United States in the late 90s. It was covering 7 serotypes and was able to show a marked reduction in community-acquired pneumonia, meningitis, bacteremia, and it's a very, very effective vaccine, except what happened in the discussion about necrotizing pneumonia. So by the end of 2007, which was around the time that our paper was published, essentially the pediatric population in the United States had 3 to 4 doses of PCV7, so almost everybody was immunized. So why did you start to see this complicated course, and could it be connected to the introduction of the streptococcal pneumonia vaccine? So this is one of the papers that gives the first notion that it may actually be the case. This was an 8-center study that looked at the course of pneumonia in children who were hospitalized for pneumococcal pneumonia, and some of them developed complications, predominantly pleural effusion. And when they looked at the complicated versus the uncomplicated pneumonias, and they tried to split by types. When they looked at type 1, that is not covered with the pneumococcal vaccine, type 1 was in 4% of the uncomplicated pneumonia, but in 25% of the complicated pneumonias, which raised the question whether could this be that the PCV7 actually allows the non-PCV type to actually rise and be more prevalent, because we have wiped out the 7 more prevalent disease types of pneumonia. And so the question was, are we really seeing more of the necrotizing pneumonia as a complication of pneumonias. This was the original title of our paper, that we said that necrotizing pneumonia is an increasing complication of community-acquired pneumonia in childhood. And the reviewers did not allow us to say that because they said, well, you're doing much more CT scans. It may not be for real. You may be just diagnosed this more frequently, but it doesn't mean that it actually goes up. And so we had to say that it is an increasingly detected complication in pneumonia. However, a number of studies suggest, including this one in 2017, suggest that it really is increasing in numbers around the world. And there were some studies within the United States that actually showed that the numbers have been growing of necrotizing pneumonias as time went by. And in this study from Salt Lake City looked at necrotizing pneumonia between 1997 and 2000. And what they showed is 13% of their children have shown necrotizing pneumonia. And when they showed the later phase, again, to remind you, this is when more and more children became immunized with PCV7, they showed that it went up to 33%. And in this population, specifically in Salt Lake City, they were able to show that PCV7 did not cover type 3. And type 3 was the predominant necrotizing pneumonia agent in their necrotizing pneumonia population. So what emerged then is that there has been a process by which the increasing infections with non-PCV bacteria types of pneumococcal vaccine took over and became relevant where they were irrelevant before the PCV7 types were not wiped out. Let me just refer to this paper. I would suggest that all of you read it. I think it is a remarkable study on serotype replacement in disease after pneumococcal vaccination. So this is a really intelligent, I think it's the best paper written on the topic. And what they are showing is that it's called serotype replacement. There is strong evidence that colonization with non-vaccine types increased in the vaccinated population, and non-vaccinated type have increased among symptomatic carriers in a process dubbed serotype replacement. To a lesser extent, non-vaccine type have increased as cause of invasive pneumococcal disease. So there is a replacement and also an unmasking of types that were not seen before. So here is the good news. By starting 2010, PCV13 was introduced with with 6 additional types, and in addition to the PCV7, and these led to a very effective reduction in invasive pulmonary disease in children in the United States. So since 2010, we start to see a marked decline. So of the complicated pneumonias, here is early 2000 decline with PCV introduction, but the PCV13 actually basically that were the predominant types during these years have actually been substantially reduced when the introduction of PCV13 came. These are data from the CDC, and the only thing that did not change is that the ones that were driven by the by the non-vaccine types, the rare types that were not covered by PCV13 remained the same prevalence, but relatively low. So everything that had been driven by the types of pneumococci that were driven by the PCV7 and then the PCV13 has been dramatically reduced. And what you can see here is that so this is again the same data from the CDC. This is a marked decrease in all what they call invasive pulmonary disease. And then this is separating the PCV5, only the ones that were the added type at the introduction of PCV13. And you can see that they are going down dramatically. and I think we can skip this one, but this is giving the numbers for the estimated death or cases prevented when PCV13 was introduced. And what you can see here is that the estimated prevention is 30,000 cases of invasive pneumonias and 3,000 deaths between pediatrics and adult populations were prevented by this introduction. So very good news. Similar data were shown in other countries. This is actually data from Israel that are essentially replicating what I just showed. Let me just tackle one last thing, and I know that I am almost over time, but I would like to talk a little about the pleural complications here. Children with necrotizing pneumonia mostly present as complicated pleural pneumonia. Pleural effusion is the initial therapeutic challenge in this complex disease, and the recognition that a necrotizing pneumonia complicates the disease comes late in the course when the treatment for the pleural disease is ongoing, but symptoms do persist. And it is the pleural element that is typically extends the course. So just to mention that 83% of necrotizing pneumonias in our studies actually had a pleural disease. And this study that we did in the early days showed that when the bronchopleural fistula, meaning a leakage of air into the pleural space, which is extremely unusual in regular pneumonia, is quite common in necrotizing pneumonia. And in fact, out of 9 children that we were analyzing, 5 had bronchopleural fistula, and it is a very different situation compared to abscesses. And so here is what our study later, so this was early 90s, and the summary of our 80 cases showed that 83% of patients had pleural effusion, 76% had drainage, the median duration of the drainage was 6 days, and 15% required surgical intervention for the drainage, but not for lobectomy. 10 patients, 12.5% had bronchopleural fistula. So this is something to take home. This is a condition, perhaps the only condition that I can think about in pediatrics that leads to a high incidence of bronchopleural fistula. And what we have seen is that bronchopleural fistulas did not occur in children who had a drain less than 7 days. So our interpretation is that leaving the drain for a prolonged period of time may be the underlying reason that the fistula occurs. Here is an example of how fistulas occur. You can actually see the drain connecting into, probably eroding into the lung. And we think that there may be an area of weakness where you have a pleuritis and a plastic eroding against it that may actually perforate the pleura. We have no proof for that, but what I can show you is that this kid a year later has been completely healthy. So you don't necessarily need to resect this lung. We actually went for over 2 months with this kid with drainage alone. What can also happen is that the drain actually goes into the parenchyma. This is of course less common, but it's a possible complication that one has to keep in mind. So given that 83% of the cases in our series had the pleural effusion, a serious conundrum emerges, namely whether the severe morbidity conventionally attributed to the empyema may in reality be reflecting the underlying necrotizing pneumonia. No study ever attempted to uncouple coexisting pleural effusion and necrotizing pneumonia. The treatment of pleural effusion in the face of necrotizing pneumonia may require a more cautious approach, attempting to minimize drainage time because of the risk of bronchopleural fistula. We think that the incidence of bronchopleural fistulae had decreased since we have become more conservative in the use of pleural drains, but we cannot prove it because we don't have enough numbers. So in my mind, the magic number is 7 days. Try to leave the drain less than 7 days. So the last thing that I want to tell you about is that it is, I think, an enormous error to view necrotizing pneumonia as a lung abscess, in particular, if this will lead to manipulation and attempted drainage of the quote-unquote abscess. this is almost guaranteed to lead to a bronchopleural fistula and complicate the care and outcome. And as I told you, it is the bronchial complication, the bronchopleural complications that are leading to many of the very prolonged courses. Because once you have a bronchopleural fistula, even if the lung disease is much better, as long as the fistula is active, you cannot really discharge the child. And the choice of taking the child to surgery is not a good one. I'm not going to tackle this, this last piece of my talk. However, if you're interested in late pleural complication, this is a paper that was published by Nadir Demirel about 2 cases of pneumothorax and tension pneumothorax complicated the course, but that's very, very uncommon, and I don't think that we should elaborate on that. So I suspect that we have 2 or 3 minutes for questions if anybody has any.
Thanks, Dr. Colin. That was a great talk. I think a good topic to be thinking about for the fellows as they're heading out into practice. Yeah, if you have any questions, please enter them in the chat box, maybe not the cat box. Looks like we have one question from Dr. Keltermans. It says, should we interpret the impressive regenerative capacity some of these children displayed as an indication for the presence of pluripotent stem cells in the lung? So why do you think there's so much recovery?
So Jelte, this is a great question, and I wish I would know the answer. All I can say is that the big question, the real big question is the classical teaching, not so much about alveolization. I would suspect that if you would be destroying almost all the alveoli in a baby, the alveoli would be regenerated very, very rapidly because the ability to regenerate in the young and the pace of the regeneration of alveoli is incredibly fast. The question is mostly about the bronchi, because what we have been taught classically, and it appears that it also is being contested in recent literature, is that the bronchi, the bronchial tree, until the 16th generation is formed by 16 weeks of life in utero. And if you destroy them in utero or damage them, you can't compensate. And if you do a lung resection and if you resect the bronchial tree up to the 16 parts of bronchial tree up into the 16 generations, you will get compensation with alveolization, but not regeneration of bronchi. So the question is, if this necrotizing process destroys bronchi, how are they able to regenerate? And they do, because the pulmonary functions seem to go back to normal. So that may be by, yes, pluripotent cells, or the other possibility is that as you're destroying the lung parenchyma, you don't really destroy the bronchi, but they actually sort of telescope into the mediastinum. And as the lung recovers, they grow, they expand back, and they are not really needing regeneration. They only need to be regrowing the peripheral smaller bronchi and the alveoli. But I don't know that I know a better answer to that. But I think if there would be some type of a lung model of a necrotizing pneumonia in an animal, that would be a very good study. But I'm unaware that anybody has ever developed such a model.
Hey, can I just, Andrew, I think your latter explanation is more likely because, you know, John McBride, both in a clinical paper in JCI as well as in his ferret model, I mean, I think pretty much clearly showed that, like, if you take out airways, they don't grow back again. And so but of course, alveolar growth continues. So there might also be some remodeling of existing airways, but I think your latter explanation is probably more accurate than that the airways themselves were destroyed.
I would have agreed with you until recently, but there is a study by I think the first name of the author is Narayanan, that looked at animal models, and they are actually contesting this idea, and they say that that bronchi, larger bronchi can actually regenerate to an older age. And that would be, I think, actually, we should get John McBride to give a talk here in this forum next year, because I think this is a fantastic topic to discuss.
Thank you. Yeah, any other questions, please enter them in the chat. Also, you'll notice in the chat that the link to the survey is up. Please complete that and give us feedback. I think there are no other questions. We might just sign off for tonight. Thanks, Dr. Colin, Dr. Wren, for the talks tonight. Thanks to everybody who signed up and logged in. And our last talk on Wednesday. So look forward to seeing everybody then.
Thank you for your patience, everybody, staying until this very late hour. Bye-bye, everybody.
Bye, thanks.